Hi Faithful Living team members, thank you for joining in on this video. As you know, one of the challenging things about delivering annual training is reaching everybody in a format that's easy and useful. So I hope this works out for us. I know we've been trying to schedule in-person trainings and we'll plan in advance for that next year. But for purposes of getting training out this year, all employees of a personal care home are required to have 12 hours of annual training. One of the topics that we have to train on is remind you about the admissions process and some certain forms that are required by the state of Pennsylvania for our residents who live with us. And those are the pre-screen form, the DME, the documentation of medical evaluation, and the resident assessment support plan, also known as RASP, because you know how much we love our acronyms in this business. Let's talk about the admissions process and our referral sources. So that we have about 3 or 4 of our biggest referral sources, and one of them is by word of mouth. Someone may have had a loved one who lived here before and has since passed away and had a really good experience with Faithful Living and is now looking for another family member. It could be a visitor or someone who comes to do activities, who has a neighbor who's struggling or a grandparent who's struggling. So word of mouth is a really great referral source. Another big one is through the Office of Aging. If the Office of Aging gets involved with a case of someone who is struggling to live on their own, they may start calling around to personal care homes to see if we have beds available. We happen to have pretty good relationships with our local ombudsman. Those are the advocates who work through the Office of Aging, and the protective services workers there as well. So often they will call us because they have a good connection with Faithful Living and they know that we're doing the right thing all the time. Third big referral source is through the hospital. So if somebody goes into the emergency room and gets admitted and is not well enough or struggling to live at home, often we will get calls from hospital case managers and social workers asking if we have beds available. Another one is through the Veterans Program. As you know, we have a large population and our niche is really kind of towards veterans. So we do get a lot of referrals from Patriot Angels or the VA hospitals or skilled nursing rehabs. Regardless of where we're getting the referral source, we need to assess that we think that the resident would be appropriate to live in a personal care home and that we could safely care for them. So usually Sarah or myself or Subhash will schedule a tour with the family. The resident may or may not come at that time, and we do a pre-screen. And it's just a very broad screening tool that we use to say, okay, on the high level, we think that they would be appropriate and we could meet their needs. If a resident is in a hospital or a skilled nursing facility, we may go out and meet them there prior to discharge. We look at hospital records, we look at skilled nursing facility records, we look at any medical records we can get our hands on, and of course talk to the family and the resident about their needs. So this following form that you're going to see next is required. We are required to complete it within 30 days prior to admission. So it has to be on or before the day of admission. Typically, it includes a tour of the home and an interview with the potential resident and their family member. And the best practice is really to do this for even our own residents who are returning from a skilled nursing stay, just to make sure that they're back at their baseline and we can still care for the person, although using this form is not required at that time. What you see now is the required screening form from the Department of Human Services. So part 1 is the person who is doing the screening. So it can be the personal care administrator, it could be a designated person, human service agency staff. They don't normally fill this out, we do. So we print and sign the date at the top, put our name in there, and then check the boxes under IF for all of the sources we used to do this screening. This part 2 is the applicant information, and you can see in section 2D where are they currently residing, where are they coming to us from, and how long have they been there, and what is the reason for leaving the current residence. And usually just a couple of sentences in that box will suffice. We look at their level of supervision that's needed. Are they safe? Do they need any supervision while they're in the home, but they need supervision while in unfamiliar areas? And then we assess their mobility needs. This is a really tricky one because typically it's kind of hard to tell if the resident isn't there and we're trying to glean from the medical records. Sometimes if they're coming from a skilled nursing facility, the skilled nursing facility is really just looking to discharge them. And so we may not get completely accurate information all of the time, although we do try to do so. With mobility needs, this guidelines for the state is if you are independent or you need minimal assistance to evacuate in an emergency, you're considered to be, by definition of the regulation, mobile resident. Moderate or total assistance is immobile. So when you look at our mobility needs list and we kind of try to gauge how, with our staffing levels and how much a person needs prior to admission, so that we know we have enough staff to handle that number of residents. Their ability to self-administer is also evaluated. On the second page, we evaluate what needs they have for activities of daily living, which are things like bathing, dressing, toileting, bladder and bowel management, and then instrumental activities of daily living, which are shopping, doing laundry, engaging in activities, things like that. And each box gets checked for what we think that they may need. We evaluate their sensory needs and then look at all of their medical, physical, and behavioral diagnoses. History of any problematic behavior gets evaluated in that lower box, and then whether or not the resident can safely use and avoid poisonous materials. The part 3 is a determination that based on this screening, we verify the applicant needs can be met in the personal care home. And then if not, then we have to refer them to another agency, usually Office of Aging. Part 4 is not required unless you have a secured dementia unit. Once we have made the determination that we think we can meet their needs, the resident needs to go for a doctor's appointment to have this DME, documentation of medical evaluation form, filled out. It's required to be completed within 60 days prior to admission, and the regulations also do allow 30 days after admission, although we really are firm at Faithful Living that they need to have this prior to coming in, unless there would be some exigent circumstances where we needed to move really quickly, but usually they need to have it done prior to admission. It requires that it be an in-person evaluation, and every section has to be completed. Not one section can be missing, otherwise it's a violation of the regulation. If there's errors, the regulations state that a nurse may call the provider to request a correction by initialing, dating, and noting PCP next to the correction. Typically, we'll just send it back to the doctor, especially if it's an outside provider. Residents have to have a new DME annually, or if there's a significant change in condition. So, for example, a significant change in condition could be that the resident did not have a diagnosis of diabetes, and then now they have a new diagnosis of diabetes and they're insulin dependent. that would mean a new medical evaluation would need to be filled out. Other changes, a significant condition is if they go on to hospice. We would need to have a new medical evaluation done. Now on to look at the actual form. You might notice that these evaluations and forms do flow one right into the other and look very similar. So here you have the DME form, page 1. You have the resident information, date of birth, whether it is an initial, annual, or status change, the date that the resident was evaluated, and the date the form was completed. You'll see that we have to take their blood pressure, height, weight, pulse, temperature. Again, all of those have to be filled out in order for the form to be considered complete. In section 2, we start to list the medical diagnosis, but there's not much room to do that, only 3. Most people have more, so you'll see that continued on to section on page 2. Any special health or dietary needs, we need to make sure that the box is checked that the resident can safely use and avoid poisonous materials. And the reason this is because the regulations say that if we have one resident that is not able to safely use and avoid poisonous materials, all of them have to be locked up, which is definitely a task to try to manage. Immunization history, it goes over their allergies, and then it lists if there are no medications, or if they do have medications, you can circle that box, and then the provider can fill out a medication list. If they're attaching a medication addendum, each page needs to be dated and signed. It reviews their ability to self-administer medications, their special body positioning. That section 8 there is often missed, and usually it's just someone needs to check the none box. Their health status and cognitive function, again, the mobility needs looks very similar. And then the bottom section has to be filled out by the provider with their medical number. This is the second page of the DME medical evaluation. You can see at the top again the resident's name, the date they were examined, and the date the form was completed is required again on page 2. And if those are missing, which they often are, that is a violation of regulation, because the reason being is that if those 2 pages got separated, you wouldn't know whose medical evaluation this was for page 2. There's a continuation of medical diagnoses, physical and mental, and any related treatments for those. And the needs addendum, any special needs that apply. We really try to avoid having the PCP order the no added sodium, low cholesterol, heart healthy diets, because it's very difficult to monitor. Our kitchen staff does a great job tracking them when they do. But as we know that residents are adults, and they have the right to make choices for themselves, even if they're bad choices. Our job is to educate the resident and encourage them. But ultimately, if that person on a no added sodium diet demands you to give them a packet of salt, it's not worth getting into an argument about. But we do our best. And then there's a medication addendum. Usually the doctor will attach a list and sign and date each page, but sometimes they list them there. So we have a resident who we did a pre-screen on, and they got a medical evaluation, and now they're moved into Faithful Living Personal Care Home. And we will start on a resident assessment support plan. A new one of these is required upon admission annually, and if there's a significant change in the resident's condition. It's broken up, and you'll see on the next slide, the left side, the first 2 columns of the document are the assessment portions, and they need to be completed within 15 days of admission. The right-hand side, the right 3 columns, are the support plan, and they have to be completed within 30 days of admission. The RASP can be found in the resident's chart in the PCA room, and then this is a question that surveyors do like to ask team members. Where do you find the resident support plan? And that's the answer. It's in their chart in the PCA room. Remember that it's a working document and it can be updated. I call it redlining as residents' needs change. So if they're just little things, you can let the med tech or the director of wellness know that this need has changed, and they can go to the support plan and just write it in there. Each area assesses the resident's need from independent to total physical assistance or not applicable. Anything other than independent, there has to be a description of the need, a plan to meet the need, the frequency the need will be met, and the individual responsible to meet the need. The summary section in Part 3 is required, and the RASP must be reviewed and signed by the resident. This is a pretty lengthy document, so we'll take you through page by page and just give you the gist on each page. The first part is the resident's information. What is their name, date of birth, date of admission, any formal supports they have, like family, friends, physicians, who is their designated person, do they have a POA? The second part, you put the date of admission again, the date of the last assessment. So if it's a new resident, that's going to be left blank because it hasn't happened yet. The reason for the assessment, the reason for the support plan part, the date that each were finalized. Now, because this is, you'll see that with the flow of the document, typically, because that assessment part is due within the first 15 days, we typically just go right ahead and follow through and do all the care plan part as well within the 15 days. So that those dates of the assessment finalized and support plan finalized will often be the same date. Another thing to note I missed, comments or related information there in the middle of the page. That's typically where we put allergies that a resident has. And then at the bottom of the page, if this is being done due to a significant change, you have to write a description in there what the significant change was. If that's left blank on a sig change RASP, that is considered a regulatory violation. Now we're into the assessment and support plan part of things. And the first part is going to be going over personal care needs. You can see the degree codes A through E on the top left-hand box. And then the other responsible party codes, DCS is direct care staff, F is family member, C is case manager, or O is other. So on the left, you're going over 8 ADLs. Activities of daily living, eating, drinking, toileting, bathing, all of those kind of things. In the next column, you'll describe if they do have a need for that. If it's anything other than A, independent, if it's B, C, or D, you have to have something described the service of the service need, then the plan to meet the need, how frequently, and who is responsible. On this page, it's going through more of the ADLs. You see managing healthcare, turning and positioning in a chair, doing laundry, shopping, and IADLs we're getting into here. And you might recognize some of these from the pre-screen. So we do often pull out the pre-screen form. It's a very helpful piece of information when we're filling this out. Again, more IADLs on this page, using transportation, managing their finances, engaging in social and leisure activities. Again, this should look familiar, the assessment part of this type of supervision that a resident needs, and their mobility needs, as well as their needs for assistance with medication management. On this page, this is where all of their physical medical diagnoses are listed, as well as the plan to meet the need. And because we are not medical licensed providers, usually it's the residents and their doctors who are making decisions. The doctors are prescribing medications. So a lot of times you'll see the plan to meet the medical need is to administer medications per the PCP orders and let the resident's physician know if there's any concerns. Now we look at any dental, dietary, sensory, vision, hearing, communication, or olfactory needs that a resident might have, how we're going to meet those needs, the frequency, and who is responsible. This page lists all the medical diagnoses that have to do with psychological diagnosis. So this could be depression, anxiety, schizophrenia, bipolar disorder. All of those things would be listed here. Now we're into any behavioral or cognitive care needs that a resident might have. So orientation to time and place. Are they irritable? Do they have issues with judgment, agitation, or aggression, hallucinations? Communication of needs. Do they have difficulty understanding instruction, short-term memory loss, long-term memory loss? And again, you find the ability to avoid and use poisonous materials section is here. At the bottom of the page starts into their social and recreational needs. So what are their hobbies and interests? What solitary and group activities do they enjoy, if any at all? Any religious affiliation? And if the resident doesn't participate in any group or solitary activities, that needs to be addressed as well. And part 4, you have the summary and determination. Something has to be written here, just a few to several sentences on how the resident is acclimating to their new environment, or if they are a current resident and this is an annual, it typically doesn't change much year over year if the resident is stable and doing well. And we are finally to the last page. Now, the person who filled out this or did this assessment and care plan usually will be Sarah or Jody. Sometimes I do them. Their name, their signature, their title, and the date that it was signed. And the last section, part 5, is the resident's participation. So their name goes on the left-hand column, and then they must sign it if they are able. If a resident is unable to participate or unable to sign, those boxes have to be checked, and we do need to have their designated person or power of attorney sign it as well. The date that they signed it, whether or not they requested a copy of it, and whether or not we provided it. So if they requested a copy and we checked yes, the copy provided box also better be yes. So that concludes this training on the pre-screen DME and RASP process and forms. If you have any questions, please do not hesitate to come to Sarah or Jody or myself, and we can help you get pointed in the right direction. Now, for a bonus question, do you remember where the care plans are located? Have a great day, team.